We are live. Akshita, you can start now.
A very good afternoon to all the viewers who have joined us for this exclusive webinar organized by Cynodent on National Dentist Day. I would like to express my gratitude to Dr. Anmol Bagaria ma'am, founder and CEO Cynodent and Team Cynodent for organizing this event. I am Akshita Gupta, UP State Scientific Head, and I am co-hosting this session with Dr. Misbah Kadri, Social Media Director, Cynodent. And I would also like to thank Dr. Anup Dikshit Sir, UP State CD Head. Cynodent, Global Healthcare for All. Now I would like to introduce Cynodent. Cynodent brings to you Cynodent International and Cynodent India. Cynodent is a unique international digital healthcare platform, first time in the world. It is a revolutionary change brought in India by bringing a digital healthcare platform that will provide and enhance a good relationship between patients and doctors and also enables a real-time appointment scheduling system. Our goal is to create an easy and fast access to healthcare services. Cynodent is here to create precious smiles and on a patient faces with always minimum effort and maximum welfare. Cynodent International has brought for you research cell, blog section, educational programs for doctors to enhance their knowledge, skills and keep them updated regarding the recent advances and latest treatment developments. We are currently doing free webinars for students, dentists, senior practitioners from India as well as across the globe, which are different from the webinar era going on. We also design papers, mock tests, and send latest textbooks to budding students. We are trying to bring globally historic changes by uplifting our honorable profession more and more every day. Science is also working for social welfare and humanity to enhance the quality of life by providing healthcare needs, health awareness, and free treatments. For today's webinar, I heartily welcome Dr. Shadab Mohammed Sir. The topic for today's webinar is TMJ ankylosis treatment modalities. It is my utmost privilege and honor to be hosting Dr. Shadab Mohammed Sir on the occasion of National Dentist Day. Dr. Shadab Mohammed Sir has been awarded Padma Shri from the Government of India in 2019, BSc, BDS, Gold Medalist, MDS, OMFS, DSc Honoris Causa, Ballsbridge University, FDS RCPS Glasgow, MFDS RCPS Glasgow, FICD USA, FICIO USA, PFFA USA, IF Teacher, Germany, AO Fellow, Germany, WHO Fellow, Switzerland, TC White Fellowship, Glasgow, UK, Fellow Pere Potter Academy, USA, Fellow International College of Dentists, USA, Fellow of the International College of Oral Implantologists, USA. He is the Professor and Head of the Department of Oral and Maxillofacial Surgery, ex-Dean, Faculty of Dental Sciences, King George's Medical University, Lucknow, Uttar Pradesh, India. He has a teaching experience of more than 33 years, UG, PG, and PhD. His area of specialty is oral and maxillofacial surgery, temporomandibular joint surgery, orthodontic surgery, maxillofacial trauma surgery, dental implants, rhinoplasty, and many more. Sir is an UP Ratan awardee. He has more than 200 research papers in reputed index scientific, international, and national journals, published books on oral and maxillofacial surgery, and have written chapters in dental surgery textbooks. He is the chief editor of Traumaxilla, an OMFS journal. Now, I would request Sir to please start with his presentation.
Thank you very much, Dr. Akshita Gupta, UP State Scientific Head. Am I audible?
Yes, sir, you're audible.
Dr. Anmol Bagaria, founder and CEO of the Cynodent. Dr. Anup Dikshit, UP State CDA Head. Dr. Misbah Kadri, Social Media Director. I'm really grateful to all of you who has given me a chance to present this webinar on TMJ ankylosis, various treatment modalities. And I'm really happy that Cynodent just keep doing an effort to share the knowledge in the field of dentistry and especially various experts from the field of dentistry, just to bring them in a common platform and share their experiences. So since I'm a maxillofacial surgeon, I would definitely be going to talk about the surgery of temporomandibular joint, which is very common in the center and all over the world. And it is a hot topic to talk about because earlier what we were doing, just simply we were giving the patients opening of the mouth, which is not sufficient nowadays. What has come up during long time that apart from giving a mouth opening to the patient, you have to give the correction of the facial deformity. Since the time has come, then it should be managed by multimodal modalities, applying various things so that you can give best result to the patient who are suffering with TMJ ankylosis. As you know that this TMJ ankylosis is very common in whole of the northern part of this India. Many patients suffers from this disease and registered to our hospital, and we get a lot of patients. And just to know your knowledge that about 300 to 400 patients are on a waiting list for this surgery because it is a very debilitating. Apart from there is a nil mouth opening, patient is not able to eat, not able to maintain the oral hygiene, as well as there is a facial deformity, as cosmetically they are not very well accepted in this society. And especially this is very true in cases of the female patient who is suffering with TMJ ankylosis. So this talk is totally focused on the various treatment modalities to give them opening as well as just to minimize their facial deformity so that they are well accepted in the society as well as their growth is also taken care of. So these are the pictures which are showing various type of the patients having the TMJ ankylosis, their CT, their 3D scans, and the type of the surgery which we do for correction of the TMJ ankylosis. If you look into the patient of TMJ ankylosis, there you can really find out from the very far distance that patient has got some problem in the facial or the joint region itself because the patients look very, you will find a retruded chin kind of the appearance, and there may be an obvious facial deformity which may be of unilateral or it may be of bilateral. So once the patient comes to you and you examine the patient, you can really diagnose it from a very distance. So because of the obvious facial deformity, if you talk to this patient, they will definitely say that they are unable to open the mouth and their nutrition is also suffering and they have got a facial deformity. Their face is not symmetrical and their teeth are being decayed because of the poor oral hygiene. So these may be the complaint of these patients. So why it happens? Generally, if you see the normal patients, the jaw movements are because of the temporomandibular joint, which is working bilaterally. But in these patients, because of various causes, I would like to enlighten later on what are the various causes. The joint gets fixed. Every joint has got two articulating surfaces. In temporomandibular joint, we have got one condyle process and one glenoid fossa. So because of various reasons, which I'm going to tell you in the next slide, this articulating surface, they get united and because of the union, patient is not able to open the mouth and having this kind of the problem. So trauma in our country, trauma is the maximum time of the cause for this developing ankylosis. And because of the trauma to the face, there may be fracture of the mandible. And most of the time, if you see in the children, it's more common in children than adults. I would be telling you what are the reason why it is more common in children than adults. So if there is an intracapsular fracture or if there is a penetrating wound or during the forceps delivery, there may be the damage to the joint area. And because of that, articulating surface of the temporomandibular joint, they get fused, leading to the ankylosis. Then infection also can cause this kind of the problem, whereas in cases patients suffering with the chronic suppurative otitis media, or if there is infection of the mastoid process, or if there is any osteomyelitis kind of thing which is affecting to the jawbone, that may in due course of the time, if it is not properly addressed, may lead to the fixation of the articulating surface and ankylosis. Then there may be some systemic causes can lead to the ankylosis. Most of the time, patients suffering with the osteoarthritis or rheumatoid arthritis or ankylosing spondylitis. In this patient also, there are chances that articulating surface can get fused and leading to the ankylosis formation. Then some rare group of the causes may also be there, which leads to the ankylosis formation. Suppose if there is a chondroma or osteochondroma, osteosarcoma, or if there is a metastasis to the condyle area or the joint area from distant site, if it is not addressed in time, they may also lead to the closure of the mouth and ankylosis in this patient. There may be some miscellaneous group of the causes like Marie-Strumpel syndrome is one of the cause where there is a chondromatosis in this patient. Early fusion of the all joint of the body is there. There may be a gait change also, and there may be facial appearance changes also because of the fusion of the temporomandibular joint. So this is one of the rare group of the causes. So how this patient looks, if you see the clinical feature of TMJ ankylosis, it is very easily to diagnose. And this patient will be having a severely retruded chin, or the lower jaw will be retruded very severely backward because there is a defect of the growth of the mandible downward and forward direction. Usually the growth of the mandible happens in downward and forward direction, giving the facial structure or the face look. But in these cases, what happens? Usually the growth center lies into the temporomandibular joint area. And as you know, that because of the various causes, it gets fused. So there is a less development of mandible and leading to this kind of the deformity. So if you try to define this deformity, various terminology have been used to define this deformity or the severe deformity, usually in bilateral temporomandibular joint ankylosis cases. So it is a kind of woggle sheet appearance, which is said woggle sheet appearance or shrimp mouth appearance. It is also known as the fish face deformity or bird face deformity. So these are various clinical terminology which can be used to describe the facial appearance of the patient which are suffering with TMJ ankylosis. It is also known as Andy gum deformity. Why it is so sad? This is a cartoon character. Like Andy Gum is a cartoon character in American Chronicle, and literally he was having no lower jaw. So the patient of ankylosis is similar to look-wise as Andy Gum. So it is also known as Andy Gum deformity. And because of the fixation of the condyle area to the glenoid fossa, definitely the growth of the mandible overall is affected, and there is a diminished ramus height. Body length is also affected, and there is a downward inclination of the mandible, and there is a compensatory change in the occlusal level of the maxilla. That is known as maxillary occlusal cant is also there. So if you see these kind of the patient, you will say there is total straight line. Chin and neck is in a straight line. This is a severely recurrent case of bilateral TMJ ankylosis. This is a Andy gum deformity kind of thing. The patient is an adult patient having a bilateral kind of temporomandibular joint ankylosis, and literally is got no chin. These are very difficult patients for intubation also. And because of this poor growth of the lower jaw, there is a lip incompetency also. And if you see the teeth of the patient is showing off. So if the patient is having this kind of the facial appearance, anybody can diagnose it easily that patient has got some problem into the temporomandibular joint. And if you take the CT/CT reconstruction or orthopentomogram and examine the joint area, you will find that there is no joint space if the patient is having TMJ ankylosis. There may be compensatory coronoid hyperplasia, and there is a mediolateral or superior inferior bone formation into the joint area. And there is a prominent anteguinal notch, which is a bony landmark, signifies the anterior border of the basilar muscle. And because if the patient's jaw is fixed, patient tries to open the mouth downward. And because of the resorption and reapposition of the bone, the anteguinal notch gets deepened up in due course of the time. Now, as I told you that in this part of the country, it is most common in children. Why it is most common in children? Because it depends on the anatomy of the local area of the temporomandibular joint, depends on the state of the periosteum in children as well as in adults, and type of the fracture which usually the child get or adult get. So if you see in the child case, most of the time, if you see the condylar neck, anterior-posterior is very thick, and the periosteum which is covering to this bone is very thin and in active osteogenic potential phase. So the bone formation capacity in children is much more as compared to the adult. And moreover, most of the time fracture is intracapsular. There is no extracapsular fracture because thickness of the neck. So whenever the child patient gets trauma, there is an intracapsular fracture, massive bleeding into the joint, and if they are not addressed in proper time, this bleeding will organize into the bone and there is a fixation of the joint. What happens in adults? If you see the anatomy of the neck, anteroposteriorly it is very thin, and the periosteum which is surrounding this bone are less osteogenic. That is, the rate of the bone formation is less as compared to the children, and most of the time the fracture is extracapsular. So there is a less bleeding intracapsular. So the chances of getting the patient ankylosis in adult one is less as compared to the children based on the anatomy. Like if you see this picture, you will find the condylar head of the child. See that there is a very thick anteroposterior neck and intracapsular fracture of the condylar head. In cases of adult, see that there is a thin anteroposterior dimension and most of the time is not able to withstand the forces which are coming to the face area, and there is a extracapsular fracture. So in this place, there will be a lot of bleeding, and that will be known as hemarthrosis, which in due course of the time will ossify and get organized into the bone if it is not treated in proper time. What is a sequelae to the trauma to the mandible? So if there is a trauma to the mandible, it will lead to the bleeding into the joint known as hemarthrosis. And in due course of the time, this hemarthrosis, this gets ossified, leading to the fixation of the joint and ankylosis. So this is a picture of the male and one female patient having a ankylosis. This patient has got right side of the temporomandibular ankylosis. And see the facial asymmetry in this patient. You see there is a lip incompetency. There is a showing of the maxillary teeth, or the teeth are procumbent. There is a flattening of the unaffected side, and there is a fullness on the affected side. And soft tissue chin is shifted to the affected side. So this is a clinical sign. If you are examining a patient with a unilateral ankylosis, and you are seeing the chin or the soft tissue chin is shifted to the affected side, that is maybe on the right side or the left side, then you can diagnose the patient is having a right side ankylosis or the left side ankylosis. This is again a patient with a facial deformity and because of TMJ ankylosis. The examination is very, very important in this patient. How you diagnose that patient is suffering with TMJ ankylosis. For that, you have to palpate the temporal mandibular joint area. You can palpate it extraorally or intraorally. Orally means inside the ear. So bimanual palpation is required. And there you can also find, if ask the patient to do the opening and closing movement of the jaw, then you cannot find out any movement into the joint area. Then you can also palpate the anterior border of the masseter muscle. This is the prominent antigunal notch. You can find out the proper groove at the anterior border of the masseter muscle. And then you can check for the mouth opening. Patient may not be having a mouth opening. So based on this examination, you can diagnose that patient has got TMJ ankylosis. Then for confirmation, you have to go for radiographic examination of this patient. Most of the hospital orthopentomogram facilities available. So this is the patient that we are showing. If you see this joint area and this joint area, here condyle is normal. You can see that gap or the gap is there into the joint area, or joint space is there. But in the affected side, if you see there is no joint space and there is a total bone formation of the joint area in the left temporomandibular joint ankylosis. There is a prominent antigunal notch as well, both bilaterally. And in these cases, it is very, very important to know the total extension of the ankylosis. If you want to that your surgery should be successful, sometime you have to be very careful while cutting the bone. So the mediolateral extension of the ankylosis is very, very important to know beforehand or before surgery. Otherwise, you may land up in problem. I would be telling you what are the complications associated with it. Then you can go for the cone beam CT also, which can give you dimension in all the direction, anterior posterior and superior inferior direction. This is a cornal section which is showing normal temporomandibular joint. See the joint space here. But in this case, right side, we are not going to get any joint space. There is a complete fusion of the joint onto the right side. Then 3D CT scan is also very informative. You can rotate this image onto the screen. You can rotate your joint mediolaterally, superior and inferiorly. In this case, there is even a cleavage line is not being shown. Where is the lower order of the zygomatic arch? You cannot see it. You cannot see this anterior posterior extension also. And this is the enlarged coronoid, which can see there is a large bonian area or prominent antegumental notch. You can see the medial extension in this section. This is very, very informative 3D CT scan for diagnosis of temporomandibular joint ankylosis as well as planning your surgery. This is again, if you see the normal temporomandibular joint, you see the gap here, but here you are not seeing any gap. So these are the diagnostic radiographs or CT scans before you go for planning of your surgery. So this is very, very important. I think most of the time, if it is a developing kind of ankylosis, you can go for ortholysis, but definitely it is got no success rate. So most of the time, you have to go for surgery. Treatment of the choice for temporomandibular joint is always a surgery. And earlier, what we were doing, we were just creating a gap in the joint area, but most of the time there is a 100% recurrence and patient are coming after some time with same condition. So nowadays, gap orthoplasty is not being preferred. You have to go for interposition orthoplasty if you want to achieve a long-term result. Interposition means you have to place some tissue or something in between the cut ends into the articulating area so that the two cut ends should not come in contact with each other and there are less chances of recurrence. So these are various materials which are being used to prevent the recurrence of temporomandibular ankylosis. Like most of the time, because we are operating in the same place, the temporal muscle and fascia are available, which are very native to that place and can be rotated and interposed into the gap which is being created by surgery. Then you can also do the interposition with the means of articular cartilage, then dermal fat, lyophilized cartilage, dura, facial lata, facial thickness, or the full thickness skin can also be used in that place. So there are various protocols because this condition has got a high recurrence rate. So it has got a various protocol which has to be followed if you want to get long-term result of these patients. So once you are operating on a patient, you have to go and do the aggressive resection of the fused bony chunk. If you are not undercutting it, then there may be the chances of recurrence. So you have to, Cohen has defined this protocol and he said that you go for aggressive resection of the ankylosed bone. Then you go for always interposition. Don't do plain gap orthoplasty. Then if you are finding that your mouth opening is not up to the mark, like not up 4.5 to 5 centimeter, then you go for equilateral or contralateral coronoid removal. And the remaining deformity you have to correct by some simultaneous procedure, or you can go in a second surgery. But you have to follow this patient regularly. Long-term supervised physiotherapy is the key to success. So most of the time, what we do, we open the joint by means of Alkite and Ramley incision, which is a combination of preauricular incision as well as temporal extension, because it is very near to the temporal. This is the area of temporal fossa, which is harvesting or housing temporalis muscle along with the fascia. So once you create a gap, you put this fascia or muscle, whatever you need in this area, and then suture it like this. So this will be a very good, or the temporal muscle or the fascia is a very native to this place and very good thing to interposition the material. Then this is again a patient with a temporomandibular joint ankylosis. This is the temporal fossa, and we have lifted the temporal fascia. A wedge-shaped tissue has been taken off from the temporal fascia, and interposition of this temporal fascia has been done into the cut area. So merit of this fascia is what? It is very native to this place. It is very pediculated, so the regeneration or loss is not that much. It prevents the re-ankylosing because it has got a thickness, so it acts as a cushion to the trochlear area, and it is uptake is very good because it is a pediculated. It has got its own blood supply. The second thing which can use for preventing temporomandibular joint ankylosing is dermal fat grafting. This is a patient with the right side ankylosing. This is the harvested dermal fat and which is being placed into the joint area, and this is the mouth opening of the patient. This is again a very good thing which can be used. This is the how we harvest the dermal fat. The lower abdomen you can harvest after deepitalizing. You can harvest as much as dermal fat you are required. This is the patient with the dermal fat into the joint area. So the merit of harvesting dermal fat is that definitely it is used for prevention of re-ankylosing, and it has got a thickness and a bulk, so it just act like a cushion and prevents this recurrence. But definitely, once you are taking a graft from the donor side or distant side, there is a donor side morbidity involved in it, and there may be chances of recurrence if the fat gets dissolved. So this is very interesting. We can always use the auricular cartilage, which is very well cosmetically cited incision. This is the harvest is from the posterior aspect of the ear. This is the cartilage which you have taken out, and then this cartilage can be placed in the cut area, and the cartilage, it is avascular, so it does not resolve under the massicatory forces, last for a long time, and at the same time prevents re-ankylosing. Then nanoplastic material, you can use the silicone blocks, which are ready-madely available, square or different shape. So according to your need, you can carve it out and then place into the glenoid fossa. And this is again a thing or alloplastic thing which can prevent the re-ankylosing. But sometimes it gets associated because of the body reaction. So this complication is always associated with that. So apart from giving opening to this patient, it is very, very important that you look for the deformity correction also. And it is nowadays we do correct this kind of the deformity simultaneously, or you can go for at later dates also, you can go for the second surgery. And what are the things which are we doing for correction of this deformity during the simultaneously treatment of the ankylosing? So as you know that growth center is damaged most of the time in this patient because of the fusion of the condyle to the glenoid fossa. So definitely there is a growth center damage. So we have to give certain thing which can act like a growth center, or you have to restore this ramal and condylar unit so the deformity can be minimized. So what we do generally after gap orthoplasty or just opening of the mouth, we do the rib grafting that is known as costochondral graft. It has got a costal part as well as a chondral part. So this is the rib graft which is being harvested. This is the cartilage and this is the costal part. Cartilage part is always towards the glenoid fossa. So what happens is, what is the logic of giving this graft? So when the cartilage grow in superior direction, it pushes the mandible forward and downward. So it minimizes the facial deformity, but sometimes, as you know, that it is most of the time autogenously condylar reconstruction used for autogenous condylar reconstruction. Most of the time, fifth or sixth rib is being taken off, and 1 centimeter of the cartilage or chondral cartilage is being taken off, and it is being reported the disadvantage of the graft. Sometimes the cartilage keeps on growing, so there may be a formation of contralateral deformity. So just to minimize this kind of the complication, minimum amount of the cartilage, like 2 to 3 millimeters, has to be taken, and it prevents the overgrowth of the graft and contralateral deformity. But if it happens, then you have to go and do the correction. You remove the graft or the cartilage part, and if it is required, then you go for various osteotomy procedure of the mandible to correct the cross bite in this patient. The advantage of costochondral graft is that it is a biological compatible. There is no adverse effect to the body, and it has got a remolding capacity. In due course of the time, it remolds like a temporomandibular joint, and simultaneously it has got a growth potential, so it helps in minimizing the facial deformity as well as. But as I told you, there may be a limitation. Sometimes it overgrows. Then it causes the contralateral deformity, which needs a surgery, second surgery, to remove this graft and do the correction of the deformity again. And there may be the chances of recurrence or re-ankylosis, and it may be having a poor quality of the cortical and medullary bone, because if you take the section of the rib, it is very thin. It may resolve due to some infection and all. So you have to take, these are the limitations associated with the graft surgery. So this I'm showing one of the patients which we followed for about 25 years of the time. This is a 7 or 8 year child having a left side of the temporomandibular joint ankylosis, where we did this costocondral graft. Once we followed this 25 years, we found that the chin has shifted to the right side. So that complication which I was talking about, that sometimes it overgrows. So it creates a contralateral deformity. This patient needed a second surgery. We did sagittal split osteotomy of the mandible and got this thing corrected again. The second graft, which has got a growth potential and it is very useful to the joint area to prevent the recurrence as well as giving a growth potential to the mandible, it is sternoclavicular joint graft. It is also known as the clavicle graft. It is a clavicle or the clavicle graft. So it is more similar to the temporomandibular joint. Overgrowth is also not being reported, and it is very stronger as well as the strength of this graft is concerned. And it is development wise, ontogenetically or phylogenetically, it is very similar. Growth or evolution wise, it is very similar to the temporomandibular joint. You can take whole of the graft, whole of the joint, sternoclavicular, as well as in cases where you can take top half of the graft with a capsule as well as disc. So it is very well similar to the temporomandibular joint. This is a picture which is showing harvested sternoclavicular joint graft. Production of this graft to the joint area is done by submandibular approach. Fixation of the graft is being done by the various screws. This is the orthopentagram, which is showing the graft is being fixed with the help of the screws. It is very similar to the temporomandibular joint. And head of the clavicle has got a cartilage layer, which is very much similar to the condylar edge, and it has got a growth potential. So once it grows, it pushes the mandible down and forward, minimizing this facial deformity in these patients. And if the whole joint is being used, it has got two compartments like temporomandibular joints, superior and inferior compartment with a disc in it. And the beauty of this graft is that after taking it out, if you suture the periosteum properly, whole of the clavicle gets regenerated within 6 months of the time. So patient has got no post-surgical deformity. Whole of the clavicle gets regenerated. Third kind of the graft, which is usually we use for reconstruction of temporomandibular joint, is fibula bone graft. It is very good bone, very thick corticocancel part is there. By doing various osteotomy, you can reshape it according to the joint, and you can carve it out and can be easily fit into the joint area. And only disadvantage is that it lacks the articular cartilage, but it can also be used as a growth potential. It has got a growth potential. This is the surgical procedure, how it is being harvested. This is the fibula graft, which is being taken off. Then you have to give a V-shape osteotomy in it, and then you can use accordingly whatever shape is required. You can use it. So this is again a iliac crest grafting. It is a kind of the chondroiliac crest graft. It has got a growth potential. So you can take a full thickness graft, and rather than you can just take a section of it. As you know that ilium has got a growth potential in a vertical direction. So once it goes down, then it gives downward and forward growth to the mandible, and facial deformity can be minimized. This is the patient where we have taken out the iliac crest graft, and according to the need, this can be carved into the condyle and ramal element. so that condylar lemon reconstruction can be done with the help of electron graft, which is very good autogenous kind of the graft given for minimizing the facial deformity and correction. This is a patient after gap orthoplasty where we have given this iliac crest graft. This is a PA view of the mandible showing the graft in place with the help of screws. So this is one of the option again for minimizing the facial deformity as well as giving a mouth opening to the patient. Then sometimes coronoid process is also used for reconstruction of the condylar head. After doing the condylectomy, it is being shaped into the condyle and then can be placed into the joint area so that condylar ramen length can be restored. So Cabin was the person who just modified this kind of the treatment options which are being available by, and he said that after doing the gap orthoplasty or osteoarthrectomy, you do the distraction osteogenesis, cadence lengthening procedure, which can also be very useful for lengthening of the bone, like in the long bone. Go for some graft, which is being used for reconstruction of the ramus or condyloramal unit. In cases where you're going to do the distraction osteogenesis, you can mobilize the jaw early. But in cases of costochondral, you have to just do the movement after 10 days of maxillomandibular fixation. Then now the concept has been changed. Nowadays we are just our focus is to replace whole of the temporomandibular joint. Various things are available in the market, or you can indigenously make your joint by various means. So this is the patient's OPG showing titanium condylar prosthesis, which is again a load bearing, and because it is a metallic one, and it gives a good strength to the condyle area. Patient can do very good function, and it is a bit costly, so the patient who can afford it can be used properly. Sometimes if it is not be properly being fixed, then there may be a hardware failure, or it is a costly also, and there may be chances of infection. So this is very interesting. Poor patient, we can go for whole joint replacement. This is a polymethyl joint, which is being indigenously formed by denture material. Various sizes of the glenoid fossa as well as the condylar head, they are being carved into the wax, and then they are cured. And according to the need, they are customized to the patient's needs. And this is the patient's or the clinical picture, which is showing glenoid fossa has been fixed to the lateral attack of the zygomatic arch with the help of screws. And this is the ramal element which has been introduced from the submandibular approach, and it is being fixed with the screws. This can also be one of the options when various processes, glenoid fossa as well as the condylar elements, they are market available into the market. This is the one of the Christiansen's processes, which has got condylar processes and the fossa eminent processes. It is made up of chrome cobalt alloy, and condylar element is being made by polymethyl acrylate. But they are really costly affair, and most of the patients they are not able to afford. Then Lawrence prosthesis is also available in the market for whole joint replacement. And the basic goal is to maximize to do the maximum contact with the glenoid fossa as well as condylar head. So the mandibular component is made up of chrome cobalt alloy with roughened titanium plasma coating in it. So the reinforcement is very good in this kind of the processes. And the fossa element is made up of ultramolecular weight polyethylene called ERCOM, and which is being made of biomet. So biomet joints are also available in the market. Then TMJ concepts or tech media has also come up with their whole joint replacement. They are really customized individually according to the patient's need. This requires a patient CT data, which is being converted into the DICOM images, and then these DICOM images they are sent for 3D printing, and they print the whole of the temporomandibular joint or the glenoid fossa, as well as condylar ramal element according to the need of the patient. So this is one of the clinical picture which is showing CAD/CAM designs glenoid fossa as well as condylar element fixed after TMJ surgery. So nowadays the basic focus is to just do the total replacement of the joint so that you can minimize the facial deformity. In the same time, once you are releasing the joint, this patient I'm showing you has got a severe or recurrence ankylosis, bilateral of the temporomandibular joint. See the facial deformity. Literally, she has got no lower jaw and she is psychologically very much depressed because of the bilateral TMJ ankylosis, in which we have done the bilateral joint replacement. This is a CT scan of the patient. See, after this is the gap arthroplasty which you have done. There is a coronoid enlargement. This is the orthopentagram showing the gap which is being created after doing the bilateral TMJ osteoarthrectomy. And this is a condyle glenar fossa component. This is the glenar fossa component which is being fixed to the lateral aspect of the arch by means of screws. Then this is the condylar, the ramal attachment, which is again fixed to the lateral aspect of the ramus of the mandible with the help of various screws. And in this patient, there is if it is a bilateral kind of ankylosis, definitely maxilla compensates for occlusion. And most of the time, if you go and examine this patient, you will find that there is a canting of occlusion. One side of the occlusion will be down and one side of the teeth will be in up. So what we do the simultaneous surgery of the maxilla also. We do the down fracture of the maxilla, and then we have to just correct the occlusion of the mandible, and this down fracture of the maxilla is refixed with the help of mini plates or the microplates, whatever is available. Correction of the canting of the occlusion is done. So this is a simultaneously surgery on the mandible as well as the maxilla. This gives a good result and in a single surgery. This is the same patient after bilateral temporomandibular joint replacement. If you see, this is a 3D lateral reconstruction, which has got a glenar fossa component, which is being fixed with the screws. And this is the ramal element, which is being fixed with the screws also. This is a front view of showing the bilateral temporomandibular joint prosthesis. And this way you can do the correction as well as give function to the patient in a same surgery. Then whatever surgery you do, it is being shown, it is being seen that if you do not follow this patient properly, out of the pain, the patient do not do the physiotherapy post-surgically or post-ankylosis or post-osteoarthrectomy. What you have to go and you have to call the patient for quite some time and put this patient on under active supervised physiotherapy, which can be done by jaw exercises, which can be done by wooden aspirin sticks, or there are various kind of the jaw openers like joint detector, Ferguson mouth gag, keisters, various kind of the opener for the mouth is coming. So you have to go for a long-term supervised physiotherapy if you want to get a long-term result. Otherwise, recurrence rate of this surgery is very high and patients come back to you with the same problem. And recurrence correction is very, very difficult. It takes time as well as a lot of difficulties there to release the joint again. And intubation in this patient is also very difficult. That thing has to be taken care of again. So what are the various things which you do for correction of deformity after surgery? So this is a patient which being operated for temporomandibular joint ankylosis. See, there is literally no chin. Why there is no chin? Because of the growth disturbance in these patients. So we do the distraction osteogenesis like bone lengthening, but that is just to avoid the osteotomy in this patient. These are the various steps how we do the bone lengthening in this procedure. This is the corticotomy which is being done, and then this is a distractor which is being placed. And once there is, we do the callus lengthening. This callus gets lengthened off, and later on this ossifies and just gives length of the growth potential to the mandible. And at a later date, we remove this distractor. This is a kind of the extraoral distractor. In earlier we were using it, but nowadays more miniaturized or intraoral distractors has come up. So this kind of the facial scar is being avoided nowadays. So this is the beginning, which can also be used for correction of facial deformity or maintaining the length of the patient. This is again a patient of TMJ ankylosis. See, the length of the chin is very less, but because of external distractor, see whole of the chin and the length and the volume of the chin have been restored to this because of the distraction of osteogenesis. This can also be used for correction of the facial deformity. Then this is a patient where we have used the intraoral distractor. This is cosmetically well accepted. There is no extraoral scar formation, and it is very useful for female patients. So that can also be used for correction of this kind of the deformity. This is again a pre and post-operative picture of a patient where distraction of osteogenesis has been done. This is the patient with the right side of TMJ ankylosis, and this is the post-op view after distraction with a good amount of the chin. This is again a one patient. See, there is hardly any chin. Chin is placed very backward, but here see lot of mantle-level fold and prominent chin volume is restored by means of distraction of osteogenesis. Then, as I told you that this patient is a caught ankylosis, definitely the maxilla has got also defect. One side it is down, one side it is up. It is a canting of the occlusion, which we correct by simultaneously doing surgery on the mandible and the maxilla. Down fracture of the maxilla is being done by left forward osteotomy, and then with the help of you can go for maxillary dissection if there's a hyperplasia also, or you can just do the correction of the cant of the maxilla and the mandible, put this jaw in proper occlusion, and then fixation of the fragment. So if you see, this is a canting of the occlusion. See, this side of the teeth are down, this side is up after surgery, putting up left forward osteotomy. This side, if you see, the plate is being used for fixation of the maxilla. This is intraoral distractor, which is being placed for correction of the rest of the deformity. So that way you can do the simultaneous surgery of bilateral jaw, that is the maxilla as well as the mandible. One minute. Okay. This is again, this is the preoperative view of the patient, seeing the maxillary cant and ankylosis. This is the post-op patient after doing the distraction of osteogenesis and down fracture of the maxilla. There is no chin, but in this patient, you can find out there is a chin formation. So, next thing which you can do for correction of the deformity is the transport distraction. From remaining ramal stump, you can do your osteotomy and just cut it, and a distractor is being placed, which is opened up. That fragment goes into the glenoid fossa, and because of later on remodeling and all, this can be a kind of the condylar head formation. So dissection osteogenesis can also be used to correct the deformity because it is autogeneous, it is more easily accepted into the body. Then there are various kind of the surgery. After doing this kind of the things, still if there is a deformity which is being left, this is a patient with bilateral TMJ ankylosis which you operated for opening the mouth. After opening the mouth, we just do the genioplasty, and then this chin can be advanced. This is the pre-genioplasty picture of the patient. This is the post-genioplasty picture. This is the front view of the patient. This patient was being referred to here from J&K state. Literally, she was not having any lower chin. After doing the gap orthoplasty, opening of the mouth, we did the gap orthoplasty, and see the total volume of the chin and the improvement in the facial profile of the patient by doing a simple genoplasty, which is very simple surgery, can be done under local anesthesia also. Then sometime the difficult cases can come to you. Literally, this patient was having no chin. After doing gap orthoplasty, opening the mouth, chin volume is, there is hardly any bone into the chin area. So you cannot go for genoplasty or the conventional genoplasty procedure. Then you can use a camouflage kind of the surgery by using Mat4 implant, which you can go for intraoral. Definitely the patient is a female. You don't want to give any scar outside. Go to the chin area, approach it with the vestibular incision, and then accordingly you have to carve your Mat4 implant and fix with the help of screws. So this is the patient onto the table after putting a camouflage surgery by means of Mat4 implant. This is a lateral scapulogram, which is being showing advanced soft tissue chin by means of Medpor implant. So this can also be done for comma fresh surgery. This is again a patient with Medpor implants. This is a pre-operative picture, lateral profile and front profile, and this is the front profile post-operative. See, good facial appearance improvement as well as volume of the chin has properly been restored. Here you see there is a straight line, there is no ventral fold, but here is a very cosmetic appearance of the chin you can give to this patient. Then sometimes patient is having condylar hyperplasia, so there is a total cross bite, class 3 mandible is there. You can go for correction of this deformity, like this can be done by means of bilateral sagittal osteotomy and pushback procedure of the mandible. This is a 3D reconstruction or of the patient showing the class 3 malocclusion in this patient because of the condylar hyperplasia. Then by doing this bilateral sagittal osteotomy and mandibular pushback as well as correction of the maxillary cant in a single procedure, you can do the improvement in the facial profile. This is the post-surgical occlusion of the patient. This is the lateral profile of the patient after pushback of the mandible by means of sagittal split osteotomy. So this procedure can be used to minimize the facial deformity in these patients also. This is a pre and post lateral view of the patient. See the position of the mandible here and the position of the mandible here. So the correction can be done by means of this surgery. When we also use a lot of time tissue engineering and stem cells. As you know that stem cells has got potential to change into a different kind of the cells. What we do after doing gap orthoplasty or transport extraction, we take a hydroxyapatite scaffold and then put a osteochondral strut, which is consisting of chondrogenic cells and osteoblasts along with the osteogenic cells. And it due course of the time, all of this they form a new condyle in this area. This is again under a trial and has got a promising results. So, like in any surgery, TMJ surgery also got complication associated with it. There may be the chances of re-ankylosing, and this is very great problem. Rate of re-ankylosing is very high in this patient. As I told you, the post-op physiotherapy as well as adequate removal of the bone from the joint area and proper surgery and interposition is very important in this patient. If you want to avoid the recurrence, then if you are stretching a lot into the surgical area, your incision is not proper. If it is a short, then you have to do a lot of stretching in that area, which may lead to the facial nerve paralysis. Patient will not be able to wrinkle onto the forehead, as well as patient will not be able to open the eye on the side. It may be a transient or it may be long-standing, need a proper address. Then, if your incision is not correct into the hairline, then there may be the chances of after healing, there may be the chances that hair will not be going to that area and a visible hairless area will be there, which patient, especially the female patient, will not like it. Then if there is a lot of bleeding which goes into the ear canal, get deposited onto the eardrum, may lead to the postoperative deafness. Or if you are not doing the medial extension of the ankylosis, and if you are keep cutting the bone onto the medial aspect of the condyle, there may be the chances of damage to the second part of the maxillary artery, leading to the hemorrhage, and there may be emergency. So you have to take care of this complication as well. So the golden rule of correct doing overall management of TMJ clothing is that don't go for only gap orthoplasty, go for osteoarthrectomy. Osteoarthrectomy means removal of a chunk of the bone, which should be at least 0.5 centimeter to 1 centimeter. Then put something in between the cut ends. As I told you, there are a lot of things available. Do the interposition orthoplasty. Then for extra gain in the mouth opening, remove the cornea process. Usually the removal of the cornea process gives an additional gain in the mouth opening like 0.5 to 1 centimeter, and then go for long-term supervised physiotherapy. Then chances of recurrence may be less. But now because of the changing trend in the Management of post-ankylosing deformity. As I told you, go for total joint reconstruction. This way, you can restore the normal condylar height after surgery. Then, for procumbent teeth and all, go for the orthodontic corrections. And again, put the patient on physiotherapy so you can get the best results. So, the take-home message of this correction of the ankylosis as well as post-ankylosing deformity is that it is not nowadays, in a recent time, it is not a single surgery that will give you the good results in TMJ ankylosis management. Like if you go for gap orthoplasty or interposition orthoplasty, what you are going to get only a mouth opening to the patient and function. And you know that you are given the function to the patient, and whatever correction may be in the deformity, that will not be optimum. You have to supplement or support by various things which I have already told you if you want to get the best results. So it is the need of an hour to do the mouth opening simultaneously as well as do the correction of the facial deformity. And this can be very well addressed like you are giving the mouth opening and function to the joint. What will happen? It will be governed by functional matrix theory because you are giving a function to the joint. Patient will do function and whatever growth will happen, it will happen. But definitely it is not going to correct whole of the deformity. So just to correct it further, you have to think of something else like growth central transplants by means of rib graft or clavicular graft. And the various graft materials there are available, as I have told you. Then in patients which can afford, you can go for whole joint replacement, and the deformity can be corrected by restoring the vertical height of the ramus of the mandible. Then callus distraction is again one of the choice in the form of distraction osteogenesis. And in case of condylar deformity, you have to go for osteotomy, doing correction of the post-surgical deformity. And TMJ bioengineering and stem cells is a talk of the recent area, which you can also try. So ultimately, from foregoing discussions of TMJ enclosures like giving mouth opening, doing correction and all, these are the things which you have to look for multimodal approach to the joint diseases like TMJ enclosures and giving the patient best results. What will it go for? Go for interposition orthoplasty. Then the first go, you can go for growth central transplant by means of costocronal graft or sternoclavicular joint graft. Then you just supervise this patient for active supervised physiotherapy. Don't let the patient to himself. Just call the patient to the hospital back to you and ask the patient to do the physiotherapy by means of various gadgets. As I told you, various gadgets are available for it. Then if there is a maxillary cant, simultaneously maxillary deformity is also present. Then in the same surgery, by maxillary surgery, you can get the best result in the same go. And this patient has to be followed for a long time to know the best result or the optimum results. So nowadays, it is the multimodal approach, which is being very much sought for best result for the treatment of TMJ ankylosis. So I think my talk, I'm finishing this talk here only. And thank you very much. And any question from your side is very well appreciated. Thank you very much once again, Dr. Anmol Bagaria,
We have a few
Dr. Akshita
questions, sir.
Gupta, Dr. Misbah Kadri, and Dr. Anup giving me a chance to speak about the TMJ clauses. I'm just over to you.
Thank you, sir.
We have a few questions, sir. If you permit, shall I proceed?
Definitely, I'm ready to give address to that question.
Which surgical approach is better in TMJ joint ankylosis?
I just best approach is Alkayat and Bramley, which is a combination of preauricular as well as temporal extension, because most of the time you have to go for interposition. As I told you, gap orthoplasty is not sufficient because it's got a 100% difference rate. So you have to rotate the fascia or the muscle. So if this incision gives approach to the joint area as well as it is give a very wide exposure to the joint area for removal of the ankylotic chunk without giving stretching to the facial nerve as well as you can visualize the whole area properly. It gives very big exposure to the temporal area from where you have to harvest your fascia or the graft, or you can look into it and you can prevent the damage to the facial nerve, as well as you can prevent the damage to the branches of superficial temporal artery, because the incision or the temporal excision grows between the anterior and posterior division of the superficial temporal artery. So it is very good, and cosmetically it is very well sited. It is given inside the screen of the ear or tragus area, and most of the incision is situated into the hairline. So cosmetically, as well as if you see the damage to the vital structures, that can be well avoided by this incision. So I think Alkayat and Brahmi is one of the best approach to the temperament joint. Any
Sir,
other
another
question?
question is, what's the success rate of joint replacement?
Joint replacement success rate is 90%, because after gap orthoplasty, you have given a glenoid fossa complete replacement, as well as you have restored the vertical height of the ramus of the mandible, and you have given a condyle to the patient along with the interposition material. So the chances of recurrence is no more. But if there is a hardware failure, or if your drilling is not proper, or if it is a misfit, then there may be the chances of rejection. Otherwise, 90% success rate is there if you're going for the whole joint replacement.
Okay, sir. Which graft have more successful result?
I think sternoclavicular joint, if you see its development and its histological structure, ontogenetically as well as phylogenetically, clavicular graft is very much similar to the temporomandibular joint. If you see it grows, it is very similar to the temporomandibular joint. It has got a fibrous disc, like a articular disc or meniscus. It has got two compartments. It is got a synovial kind of a joint. It has got a synovial membrane. So it is very much similar to the temporomandibular joint. Moreover, overgrowth of the joint is not reported. It has got a growth potential, which is required for correction of facial deformity. So if you just ask me, just compare the costochondral versus sternoclavicular, I would definitely opt for sternoclavicular joint graft.
Okay, sir. Let's move to the another question. How can we manage TMJ ankylosis with distraction osteogenesis?
TMJ ankylosis cannot be managed by distraction osteogenesis, but deformity can be corrected. TMJ ankylosis needs surgery. You have to remove the bone and just create a gap. That surgery is a different, but definitely once the condyle is fused with the glenoid fossa, so the growth of the affected site is hampered because the growth center lies into the condyle. So in that shortened site, you have to basic aim is that you have to restore the vertical length of the ramus. Vertical length, how will you increase it? By means of dissection osteogenesis, do the corticotomy, lengthen the callus by means of dissectors, and otherwise you can go for graft, you can go for whole joint replacement and restore the vertical height. So ankylosis cannot be corrected by dissection osteogenesis, but facial deformity or lengthening of the bone can be corrected by distraction osteogenesis. I think you have come to know about the difference of treatment of ankylosis and distraction. Any other question?
Misbah, Akshita.
So the next question we have is, what is the cause of deepening of the antigonial notch?
Is the cause of formation of antigolar notch?
The deepening. What is the cause of deepening
Okay.
of antigonial notch?
It depends. It is totally basic anatomy of the mandible. If we see in a normal mandible, it is not that prominent. Why it is not prominent? Because the patient is opening the mouth and doing all functions. What happens in the cases of ankylosis? Suppose there is a fixation of the joint, and if we see the anterior border of the masseter muscle, that signifies location of the antigonal notch. Why it gets deepened in the cases of TMJ ankylosis? Because once there is a fusion of the articulating surfaces, individual or the patient who is suffering with the ankylosis, they try to open the mouth continuously. And because of the continuously tension into that area, there is a pressure resorption of the bone and reformation of the bone again. So there is a resorption and simultaneously reapposition of the bone. But the rate of resorption is much more as compared to the reapposition of the bone. So because of the resorption rate, there is a deepening of the antigonial notch in cases of ankylosis because they keep trying for forceful opening of the joint. That's why it is deepened out.
Sir, with this we come to the end of the session. I would like to thank to you, sir, for the wonderful presentation,
Thank
and
you very
also
much.
Dr. Anmol ma'am for organizing this webinar, and my co-host Dr. Akshita. I would like to invite Dr. Anmol Bagaria ma'am to conclude the session. Thank you.
Thank you very much.
Good afternoon, everyone who are present here from India and all parts of the globe. I would like to thank Sir for giving us his valuable time this afternoon and for such a wonderfully informative lecture. Sir, it's our pleasure to learn from you always. It's our honor and privilege having you here today. Thank you so much, sir.
Thank you very much, Dr. Anmol, for wonderfully organizing this webinar. I think the thing which you have discussed about the TMJ clauses and deformity correction would definitely enlighten your knowledge in the field of TMJ surgeries.
Yes, sir.
Thank you very much once again.
Thank you, sir.
Thank you so much, sir. Thank you.
Thank you, sir.
So if you allow me, I'll end the session for today.
Thank you. Just finish up.